experience of 3 of the partners in the SCIROCCO Exchange project. I know we have quite a few people already joined, and some people will continue to join for the first few minutes of the webinar. Many of you will be familiar with SCIROCCO Exchange, but as we know, there are people who are joining us today, especially to find out more about SCIROCCO Exchange. Andrea Pavlickova is going to give you a very brief introduction to SCIROCCO Exchange, specifically the maturity assessment process and what that means. So hopefully that will help you to understand a little bit more about what this project is all about, and we hope you want to get involved in it as you go along. Once Andrea has spoken, then we will hand over to Igor from the Basque Country, who is with us today, and then he will give a brief presentation about their experience. And once he has spoken, we will hand over to Lithuania, to Rokas, and we will have a short presentation about their experience. And then we will hand over to our colleagues in Slovenia, and they will give us their experience. So the whole purpose is to exchange our knowledge and understanding and share some of our learning so far with this very innovative and interesting project. At the end, we will have about 10 minutes for questions and discussion. So we hope that you will be able to join us in a question. Now, a couple of things for housekeeping before we begin. We will be recording the webinar, and the webinar will be made available after today's session. So if you have colleagues or if you missed some of it and you want to listen again, you will be able to do that. When you want to ask a question, I would ask if you can use the chat function, so you can type a message, just as I'm doing now as an example, and your message will appear in the chat function. If you can do that, it helps me to keep track of the questions so that when we have a break, I can gather the questions together and put them to the speaker. But of course, if you would rather to unmute yourself and ask your question, you can do that as well. So we will not be using our cameras, I have said already. We will focus on the audio and the presentation slides. We will be recording, and when you are not speaking, I would ask you please to mute your microphone, to put yourself on silent, and only to speak when you want to ask a question, and to use the chat function if you possibly can. So the first person we have presenting today is Andrea Pavlickova. So I'm going to hand over to Andrea, and hopefully you can share your slides with us. We can see your first slide, Andrea, so thank you for that.
Thank you very much, Nessa. Glad that you can hear my slides. So as Nessa was saying in my presentation, I will just give you a brief of introduction to SCIROCCO Exchange project, its activities, ambitions, but more importantly, I will focus primarily on the maturity assessment for the purpose of today's webinar, as this is our first main area of activities. So just starting with a bit of introduction, just very briefly who we are as a project. So this is the EU Health funded program project, and we work with 9 health and social care authorities across Europe. And as you can see, they are all coming from a very different geographical location with the different organizations of healthcare systems. And we are also supported in our work by a number of university and membership organizations. In the project, we mainly focus, or our primary focus is on integrated care, and our main objective is to support health and social care authorities to successfully adopt and scale up integrated care. And we are primarily looking at 2 different enablers of this capacity building, and it's the knowledge transfer and improvement planning. However, in our project, we argue that if you want to provide a support which is really tailored to the local needs and the local priorities, you actually need to understand the local context for integration. We see that in Europe, we have a diverse concept, different models of integrated care being adopted, reflecting very different conditions and organizations of the healthcare system in Europe. So for us, it's very important as a first step to actually understand the local conditions which enables the integration, but also to better understand what are the existing boundaries and the gaps which actually needs to be removed in order to speed up the adoption of integrated care. Our second main rationale is that we don't want to replicate the wheel, replicate the efforts, reinvent the wheel, but we want to build on the existing experience and the existing evidence which exists in integrated care and continues to grow. So we are looking at the way how we can actually connect the existing evidence to the local priorities, local needs, and enable much more effective learning and improvement planning. In our project, we have been, before we actually started working on the projects, we were very much aware that actually, if you want to bring these things together, to have this better understanding of the local context and link it to the existing evidence, that you actually need some sort of like tools and frameworks which would help us to understand this processes much more in detail. And that's where we started to work on this SCIROCCO tool for integrated care. So this is the online self-assessment tool, which was developed with the objective to capture people's perceptions on the progress or the level of maturity for integrated care. So we are not using the tool to evaluate the integrated care intervention, but really looking at the local conditions, local environments, and in order to understand what conditions or building blocks for integrated care already exist in place and where are the potential gaps. And over the last few years, we spent quite a lot of time to further validate and test the tool in real life settings. And as you can see, the tool consists of 12 dimensions. Each of these dimensions represents a particular effort which one needs to do, which one needs to achieve on its journey towards integrated care. And once you register on the tool, you can see the link above. The tool is free to use for everyone to test it in different settings. You will see that each of these dimensions has its definition in terms of the objectives and also the assessment scale, which ranks from 0 to 5, which reflects basically the different level of maturity that you can achieve along each of these dimensions. And if you have a particular stakeholder or organization doing this assessment and going through all 12 dimensions, all 12 assessment scale, what you actually end up with is this spider diagram, which is the graphical visualization, or which is the visualization of the way how you can capture the maturity of particular organization or team or particular group of stakeholders in integrated care. So you will see that it provides you a very quick detection of areas where your system or organization scores relatively high relatively high in terms of the maturity. Like for instance, here you have the example of digital infrastructure reaching 5, but then you also see immediately the areas of the gaps. So like for instance, removal of inhibitors is the maturity is just 2. So it gives really quite a quick identification of your current state of art, your strengths and your weaknesses. But for us in the project, as I said, this is the first step in the process. So our ultimate objective is to develop or provide this infrastructure for the capacity building support. And for this purpose, we are developing what we call SCIROCCO Exchange Knowledge Management Hub, which we envisage will have these 4 main functionalities. And particularly for the purpose of today's call, or today's webinar, we will be looking at the maturity assessment for integrated care. So as I was saying, for us, really the key starting point is to understand the local conditions, the local priorities, strengths, and weaknesses before we can actually start to facilitate further knowledge transfer and improvement planning. And now I will just give you really very few slides as the overview of this maturity assessment process so that it provides you a bit of context before you hear the presentations from the regions on the practical experience. So as I was saying at the beginning, SCIROCCO tool is really self-assessment tool. So we are not evaluating, but we are assessing, and we are trying to capture with this assessment process the perceptions of stakeholders, how they see in their countries the readiness and progress towards integrated care. And as you could see from that quick spider diagram, we use this assessment process to identify strengths and weaknesses of particular regions or organizations, which are then brought forward in order to facilitate some multidisciplinary discussions, some dialogues, so that we can actually commonly agree on the priorities for improvements, some common actions which needs to be taken locally in order to improve the conditions for integrated care. What is interesting to say, I think, from our perspective, is that this maturity assessment process is very flexible. So we are not prescriptive by saying which level of healthcare system you need to consider, or which organizations or teams or stakeholders involved. But really, we are trying to reflect the fact, which I said at the beginning, that we are facing different organization of healthcare system, different models of care, and we also need to be flexible enough, for this process to reflect on this. So when we are talking about this healthcare system in our presentation, it's always adapted to the local context and to the local, to the local context of particular organization. So you can organize these processes at the various levels of healthcare systems, various levels of your organizations, or even within the particular teams. However, we would always consider these 4 steps for the process, which I will very briefly introduce. So each self-assessment process will consist of 4 steps. The first one is to select the people you want to involve in your maturity assessment process. So again, we are not prescriptive in saying what disciplines, what numbers, what sectors you should involve in the assessment process. But again, it reflects your local situation, your local context. But we would always encourage that the teams who are invited in these processes are multidisciplinary teams. As we are all aware, integration is about working across number of sectors, number of discipline, and more diverse teams you have worked with. It actually makes the whole exercise even more interesting. So again, you will see from the presentations from regions that there is really diversity of stakeholders who can participate in this process. In the second stage, then each of these individual person who is invited in the maturity assessment process will conduct their online assessment process. So each stakeholder is asked to register on the tool and provide their own perceptions, how they see the maturity or the progress towards integrated care. And what you can see is that you will basically end up with the number of these spider diagrams, which reflects the perception of a particular stakeholder, So you can see, either these individual insights, but which you even from these very short insights, you will obviously already see these big differences that you can see between different, sectors or discipline. But besides these individual insights, what is also interesting is that if you want to look at the, at the perceptions of a particular, of members of the same groups, like for instance, here we share with you the examples from Scotland, where we had the members of the same group, meaning the same profile, the same seniority, the same disciplines. But you can see that when we actually compare and contrast their individual responses, we still have found major diversity, which really brings a lot of insights for further discussions. So here you can see what we meant by saying, participatory tool, because we really allow every stakeholder to provide their insights to raise their voice. And this is just to illustrate how in the next stage we are collecting the data. So we have 2 ways of how you can see the visualization of your data. It will be either the spider diagrams, which I showed you even before, and this one we are using when we have the group of stakeholders no more than 6. And when we are working with more than 6 stakeholders, which has recently been the case, we have also these bubble representations to make sure that we are able to basically capture the perceptions of a larger group of stakeholders. And in the last stage, in the next stage of this maturity assessment process, we are basically bringing all these stakeholders that have participated in individual assessments together and ask them to work together to build some consensus and reach the final scoring. So they are all coming with their own scorings, with their own perceptions, but then as a team, they are asked to assess or have a discussion along each of these dimensions and really compare and contrast their stories, understand each other, how the rationale behind the scoring, and the ultimate objective of this process is that they will all have to agree on the final level of maturity. So they have to take some final decisions. And this is again just to show you the different way how we are illustrating those, the outcomes of the consensus building. So when we are using the spider diagram, the final decision of the group is highlighted in the black line, and the same is for the version where we are using the bubbles. And as I was saying, just to finalize, as I was saying in the introduction, maturity assessment for us is only the first step towards much more tailored improvement planning and knowledge transfer. So we are using the outcomes of this maturity assessment for regions to better understand what are their priorities for the next stage. So as you can see, the tool is also supporting from the functionality point of view, the identification of your areas for improvement. So in case of this visualization, if you look at the dimension readiness to change, you can choose this dimension as your priority dimensions for further work. And the reason why we are allowing this functionality is that we envisage that in the hub, depending on the level of your priorities, that the regions will be able to look themselves for the help they need, and they connect with the available assets, with the available knowledge based on the priority identified. So I think from my side, I'll stop here, and I think what will be more interesting will be for you to hear how 3 different regions have applied this process in practice. Thank you very much for your attention.
Thank you, Andrea. That was excellent. I think 1 or 2 people have some issues with the audio on their computer. Unfortunately, I can't resolve that from here. So I think that's to do with your own computer audio. I think 1 or 2 people are phoning in and watching the slides on the screen, which is an option if you have to do that. But just thinking of the time, I'm going to hand straight over to our colleagues, to Igor in the Basque Country, who's going to give us a presentation of their experience so far using the tool and the strengths and weaknesses that they have been looking at in integrated care in the Basque Country. So Igor, I will hand over to you. Thank you.
Okay. Good afternoon, everyone. And thank you, Ines, and thank you, Andrea. I think Andrea has explained a lot of what we have done in the Basque Country with SCIROCCO tool assessment in here. So let me start just from the end, and then I go back to the beginning. I would say, just in 3 words, that the SCIROCCO tool is quite simple, quite successful in our case, and useful. So this would be probably our main conclusions of the SCIROCCO tool process in the Basque Country. But let me show you from the beginning to explain, just to know these last conclusions. So first of all, probably you already know where we are in the European map. This is the Basque Country in a very sunny and warm day today here. It's not very typical, but it's a nice day today. So it's a very small country in North Spain with very high level of self-government. But I would like to just to highlight, we are within the beverage model of care. And in this slide, I would like to highlight the 3rd part of the government budget in the Basque Country is allocated in the health system, which is a lot of money. You see in there 3.8 million euros. The whole budget in the Basque Country is around 10 million. And we got social services managed by local and provincial authorities. This makes it a bit difficult in order to come across the relations between health systems and social systems. And these are our main strategies. In the slide, you got the 17 up to 20, which is end up in this year. This is the strategic lines from the Basque Health Service. People as core of the system, disease prevention, promotion, chronicity, sustainability, professionals, and innovation. All these strategic lines, they got some, I say, some books where every of the strategic lines are more, let's say, developed in objectives and in scores. So integrated care in the Basque Country, we began long ago, 2009, from 2009 up to now. So it's a long road up to now, but there are basically three main pillars. One is the integrated governance, a new one for us in the Basque Country, as we got more population approach rather than disease approach. And we are sorting and setting new culture and values more related with collaborative kind of work. So that's a kind of new, let's say, culture for Basque Health Service. So when we talk about integrated care in the Basque Country, we got two main roads to get there. One is the structural integration. In our case, it tries to achieve less fragmented, more coordinated, and probably more high quality care. So merged hospitals and primary care centers under one organization. This is quite key and quite important. Up to 2009, I always say we had two kinds of let's say system. One is primary system, and the other one was hospital system with two main boards, different boards. Now we got just one IC integrated care organization, and both two organizations by primary level and hospital level and are under just one manager, one board. So we got 13 integrated health organizations up to now, about more than 30,000 people working on them. That is the first integration, it's more structural. And the second one, it probably is I would say, yeah, it's more important is functional, I would say, clinical integration is what has happened between professionals with patients and so on. So we deal with this functional integration with coordination of care processes between primary and hospital. What we are developing now is clinical pathways, policy management, and social and health coordination. These are for us what means functional clinical integration. So the process, Andrea stated very well how the process was, and this is what we did at the time with the assessment tool. First, to identify our regional stakeholders, then go to individual assessment, data collection, data analysis, stakeholder workshop, and a summary of results and feedback of the process. This is what Andrea mentioned before, so this is what we did. So in order to choose these stakeholders, we went up to 10 people to assess the tool. And we wanted at that time, in the first assessment, both the Department of Health and the provider of health, which is the Osakidetza, the Basque Health Service, were involved in the process. That was the first of the assessment of the tool. In this new one, we wanted to have another very, for us, important stakeholder, which is the citizen. We didn't have any citizens at the beginning. Probably we thought at that time that the tool is more for health professionals or decision makers and so on. But in this last assessment, we invited citizens in the process. So we got one professional from the Department of Health, from the procurement unit, from the social service, from the quality information service, one person from the chronicity service, for innovation research service department, and in frontline professionals, hospital nurse, primary care nurse, and internal medicine head of department, and one citizen. These were the people invited for the assessment with SCIROCCO tool. And these are depicted the assessment of every of these stakeholders. I guess you probably know who the citizens is in this spider diagram. Probably you already know where he is, but I won't say it. So the consensus building process, after being assessed by every of them, was in the general director of Osakidetza. We had for the process three moderators or facilitators from Osakidetza and Kronigune, and the Spanish positive language. And you got the program for that day, which began at 9:30 and ended about 1:30. So on the left-hand side, we had two groups, different groups, one of 5 people and the second group 4 people. So they had the scores, individual scores. So they had to agree in only just one score for every of the groups. So at the end of the first of this process, we had 2 diagrams, the left and the right. And after that, we had another moment of consensus moment where 2 groups were involved in the process. So here you go after the whole morning working day, how the spidergram and graphic is. If you see this, the dots, the bigger dots are the where we have a very quick consensus, and the other one we had to work a bit more in order to get them. So after this process, we have 3 dimensions. We quite well. So the structure and governance, the digital infrastructure, and our population approach. We're quite well in those dimensions. But we had, of course, some other weaknesses or key challenges for us. One is the process coordination, the other one is removal of inhibitors, and the other one is citizen empowerment. Having this, we've been doing quite a bit, let's say, projects in order to deal with these key challenges. According to process coordination, we are working now on the guide to design, implement, and evaluate all the clinical pathways in our system. Because we did know, and we do know, that this is one of our weaknesses. So we are now in that process. The guidelines now are already written, and we are deploying them through the system. The other one is citizen empowerment. As we already know that this is one of the probably key elements, and in our case, weaknesses. We've been working in deploying more or investing more in what is called in our setting the School of Health. So now there is one department just to work citizen empowerment in the Basque health system now. So to take home message or conclusions. The tool is perceived as useful for the process of negotiations, of course, reaching consensus and change management. So this is very briefly our process in assessment SCIROCCO tool in the context of the Basque Health Service. Thank you very much.
Thank you very much, Igor. That's excellent. We'll just pause for a moment while we before we pass over to the next speaker, just to check if anybody has any quick question that they wanted to put to Igor or to Andrea. I've asked Andrea and she's kindly shared the link for the SCIROCCO Exchange website, so you should see that in the chat as well. But if anybody has a quick question. No, I think you're safe for now, Igor. They're all
Thank
thinking.
you.
They're thinking of complicated questions. Okay, so I will then hand over to our colleague from Lithuania, who is next up to share their experience. So, Rokas, if you are able to share your screen with us. And
yes, hello everyone. Just please give me a second.
Thank you. Perfect.
Hello everyone. Let me, just for all of you to understand the context correctly, I would like to firstly highlight the very short evaluation of primary healthcare in Lithuania with this slide. Until the 1990s, Lithuania has been part of the Soviet Semashko type healthcare system, which was centralized, highly regulated and hospital-oriented healthcare system. And during 1990s, key laws such as the health system law, the healthcare institution law, and the health insurance law were adopted. In the 90s, many health administration functions of Lithuania were decentralized from the Ministry of Health of the country. Municipalities became responsible for organization of provision of primary care, as well as social services, some public health functions. Now municipalities are responsible for organizing and provision of family medicine, or GPs, primary mental health care, primary dental health care, and nursing care. Because of postgrad training of family physicians and retraining program for district physicians, the number of GPs in the countries has been favorably affected, and there were almost 2,500 valid GP licenses in 2019. Although mainly primary healthcare providers are public institutions, since 1998, policies have focused on the establishment of private GPs, which would involve publicly financed primary healthcare with private GPs throughout the national healthcare insurance branches. Since 2015, nurses can prescribe medical aids and have been given a greater role in providing services to multimorbid patients with non-communicable diseases. Since 2017, advanced practice nurse, like a nurse practitioner, entering the primary healthcare institutions with all the responsibilities adjacent. A lot has been done, but there is a long way ahead. This slide concludes that the life expectancy at birth in Lithuania has increased by nearly 4 years between 2000 and 2017. However, progress has been slower than in other Baltic states. And in 2017, Lithuania, together with Romania, Latvia, and Bulgaria, had one of the lowest levels of life expectancy at birth in the EU. So we need further positive changes. And for that reason, in 2017, Lithuanian Ministry of Health began health structural reform. Reform consists of 5 projects with clear objectives. Those projects are health life promotion, optimization of a hospital network, establishment of measures aimed to reduce expenditure of medicines, development of nursing care services, and other improvements. The hospitalization rate in Lithuania is higher than elsewhere in the EU, although in 20% of cases, hospitalization could be avoided by directing patients to primary healthcare establishments. In practice, periods before a healthcare service is provided are excessively long, which entails excessive waiting time or compels the patients to abandon the idea about asking for help. The patient registration system has shortcomings needed to be solved, and since it is possible to solve about 80% of health problems by providing primary healthcare services, a higher quality and availability of services must be ensured. The main goal is to provide the quality and availability of health care services, to reduce the waiting times for visits to general practitioners, as well as medical professionals, to reduce the number of cases, hospitalizations that obviously can be avoided. This is also a part of Lithuanian health strategy, which runs from 2014 to 2025, which states that strategic goal is improved health of Lithuanian population, as well as longer life and reduced health inequalities. And that was approved again in 2014. With one of the main priorities was to strengthen public health services at local level and implement innovative multimorbidity health service models at a national level. As mentioned, Lithuanian government runs structural reform at least for the last 3 years. The health system reform focuses on GP development for outpatient healthcare services, especially to implement innovative multimorbidity healthcare models on a national level. 3 main pillars that integrated care was evolving on in the past years are healthcare and social intersectoral collaboration with a long-term care delivery concept. The second one is a functional integration of primary healthcare and public health surveillance activities started in 2015. And the third one is teamwork in family medicine and has been introduced and expanded since. The team of family physician, like a GP, was supplemented by additional team members consisting of GP, nurse, midwife, nurse assistant, lifestyle medicine specialist, physiotherapist, and social worker. The new version of the GP standard was also approved in 2019. So it seems everything is going in the right direction, but all sectors of primary care in Lithuania are mature for positive change. That is a question. And how to support health and social care authorities in the adoption and scaling up of integrated care, that is probably another question. So during the assessment process, we aimed to identify the maturity of health and social care systems for the adoption and scaling up of integrated care solutions in primary healthcare centers. The outcomes of this process revealed the real readiness of our local environments for integrated care, including strengths and weaknesses, and obviously areas of improvement. The scope of the assessment consists of 4 stakeholders group, totally 65 stakeholders took part. The primary healthcare centers from different cities of Lithuania were selected as a main stakeholder group, and those were 30 stakeholders. The medical doctors from different fields, cardiologists, pulmonologists, allergists, endocrinologists, gastros, nephros, genetics, pediatricians, a total of 20 stakeholders. Government, so Ministry of Health, and patients, 14 stakeholders. Comparing the results of primary healthcare centers and medical doctors it can be concluded that some similarities exist, thanks God, but some dimensions were ranked much more positively by the primary healthcare centers. Such results may have been influenced by the specialists' more practical point of view, as they rely on practice rather than the healthcare centers, maybe. As an example, I can also compare the results of patients and the Ministry of Health. It can be concluded that there are, well, virtually any similarities at all. It highlights the problem of miscommunication between the patients and the government. There could be several assumptions about why it is happening. The Ministry of Health works on a legal basis. They are well informed and are defining their priorities, while the patients have a completely opposite view, very practical, usually very biased on their personal experience, with limited information on theoretical priorities or strategic plans. Doctors, including family physicians and medical doctors from different fields, have not enough time during the consultation time to explain all the possibilities and present additional options related to the integrated care of the patient. In any case, there is a considerable difference in the information available and the situation perceived between all groups involved, but specifically between the Ministry of Health and the patients. During the negotiation process and consensus building process, based on the total results of the self-assessment survey before the workshop, all the 12 dimensions were discussed thoroughly, especially those with the most significant differences in scoring, and the consensus was built. The following 3 dimensions were highlighted as priority dimensions for the beginning of the change, and those were process coordination, removal of inhibitors, and capacity building. So after discussing the results during the consensus building workshop, we have also tried to identify key challenges and success factors. And the 3 key success factors were pointed out as OECD in Lithuania, Lithuanian Health System review report in 2018 described primary healthcare centers in Lithuania as well developed, modern, and reflected best OECD practices. In this report, it was also mentioned that the number of GPs per population in Lithuania is higher than in most OECD countries, which sounds promising to start with. In addition to that, primary healthcare centers are willing to cooperate in order to adapt the change. And keeping the Ministry of Health on the same page helps to receive their support and put all systems one step closer to further adoption of integrated care. However, there were also challenges, and the 3 key challenges are, the first one, better intersectoral cooperation between the healthcare system and social care system obviously is needed. Sometimes it seems there's a lack of coherence between the governance and practice, as mentioned before, a lack of common views and miscommunication between the groups. The second one pointed out as a big difference between rural and urban areas and poorly developed community services network. It is recognized that there is a relatively strong theoretical background of integrated care in Lithuania. Unfortunately, the practical background is still not implemented enough and is lagging behind the legislation. And the third, last but not least, there is too much legislation and the workload of general practitioners is too large. There is a lack of time, which is available for interaction with patients, especially in primary healthcare. Another challenge that might occur is demographic change in family physicians. I mean, the 14% of family physicians are 65 and above. In 2021, more than 300 physicians will be over 70 years old. And this is this kind of is combined with a large workload for the GPs. So what is the take-home message? The assessment tool is recognized by the whole group as valuable and was evaluated positively. The results of the self-assessment process present a clear picture on healthcare systems for integrated care at local context. It helps to evaluate the situation and present rationales to policymakers, program managers, and the others interested. As in Lithuania's case, the self-assessment process facilitated discussion among the different levels of stakeholder groups. Different stakeholders' involvement allows reflecting on the situation from very different angles, as we saw before, providing very different results when comparing them. But having those discussions helps to align the theoretical integrated care implementation process with the current practice, and also highlights the dimension where maturity for integrated care is either very high or not high enough and requires to take further actions. The tool is even more useful when more responses can be obtained, and therefore simplification of the wording might be considered in the future. That would be it, and I'm open for any questions.
Thank you, Rokas. That was excellent. And I'll just ask if we have a quick question that we can put to Rokas.
Yes, we got some questions for Roka, and it's according to regarding the patient experience. Roka, how did they feel about the tool, the wording, and did they understand what every dimension meant and so on? How do you see them?
Thank you very much. Well, the wording was the part which needed more explanation, and we felt that not only the patients but other stakeholders might not necessarily understand the wording from the very first time, and therefore some introduction was needed. But once all stakeholders, including patients, were explained the tool and the wording, the whole process of self-evaluation was not a problem whatsoever.
Mm-hmm.
I'm not sure if that answered your question.
Yeah, yes, you do.
It's Nessa here. Can I come in? We've had a couple of questions also in the chat, if you can hear me well. So the first question from Maria Pia, I have. It says, from our understanding, there are different objectives of integration to be achieved. For example, functional integration and teamwork. Do you use the same stakeholders to answer the tool? Do they do all in the same round? And which objectives are they answering if they answer at the same time? We would like to better understand this because we are trying to apply the tool at the micro level of intermediate care services. So do you use the same stakeholders to answer the tool for all of the dimensions, I think that must mean? And do they do it all in the same round? And which objectives are they answering at the same time? You got that?
Is that a question for me or for Andrea?
I think that's for Rokas, please.
Sure. So yeah, so basically the tool is being used for all the different stakeholders. Same tool, same questions, and this is exactly the point that different stakeholders, or in our case, different groups, answer to the same questions or value same questions that are very different from a very different perspective. What we saw when we compared the health ministry and patients' responses, we saw that same questions were answered completely differently, which just highlights the different perception and therefore highlights the need for some action either on a communication level or just highlighting that some things just do not work in the practice. So in short, the answer is yes, all the questions are the same for all stakeholders, and they are being filled in more or less at the same time, or in our case, they received an invitation to fill in the questionnaire, and an X amount of time was given for everyone to complete their questionnaires before we started assessing and having this consensus round.
Okay, thank you. I'll move on. So we have another question from Caroline. Thank you, Caroline. Rokas mentions one of the key challenges relating to increased workload on GPs. Are there any plans or discussions taking place to alleviate the pressures, and what are the risks for patient care? That's a big one, Caroline. Big topic.
Well, this probably goes beyond this tool, but if I may take the question going beyond the tool, if we are talking about the integrated care, as parts of integrated care are things like teamwork, expanding the GP's team to include other professionals, so that those other professionals would support the GP and the patient. In other words, we have some tools which say that a specialist nurse is needed to support the GP, or a case manager is needed to support the GP. We have other multimorbidity care models which say a GP doctor consultations might be a tool to support the GP. So when we're talking about the integrated care in general, and this is my probably personal perception, as I said, going beyond this tool, we might say that integrated care is actually a support tool for the GP when building a bigger, larger group of people looking after the same patient. So my personal perception is that we are going towards a bigger support for GPs, and therefore the quality should improve and the workload should normalize in the future.
Thank you. And one very brief final question, because I don't want to lose this at the end, and apologies, Matea, we're delaying handing over to you slightly. So the question is to Rokas, but actually I think Igor also would have a perspective on this. So the question is, can you tell us more about how the tool is supporting priority setting?
I will briefly start. I would say the tool allows us to see very different perspectives or perceptions of different groups. When we have the consensus meeting, this is where the priority discussion takes place. Once the different perspectives are clear on the table, the priorities can be discussed much more efficiently. So in our case, it was really so much easier to discuss priorities when we are talking with the health ministry, but at the same time looking at the patient's perspective, who is, by the end of the day, the end result, someone who's getting the end result. So in our case, this tool for sure facilitated us to have a consensus and therefore prioritize depending on the priorities of different groups.
Thank you.
Yeah. In our case, we were not many people in the process of consensus, so probably the issue was a bit easier than the Rokas process. But I remember that day when we were just discussing and getting some of the agreements in order to score on the tool. There were lots of time in discussions, because the tool in a way gives you the opportunity to talk about many different things around integrated care, how you see integrated care in your system. So in that sense, it brings you a space and a room to talk about many things, and I think that's quite important. At the same time, the instrument, the tool allows you to say why you score that number in the process. So that's very important. Under what circumstances you are scoring in that sense. I think that's pretty important. But in our case, the other thing is that we were not many people. I suppose that when you collected lots of people, and all these people have to deal with the consensus process. I think will be very enrichment process, but at the same time, very difficult one.
Thank you very much. Just I'm conscious of time. I know we have at least one more question, which we will pick up, but I would like now to hand over, if we can, to our colleagues in Slovenia, to Andrea, Matea, who are waiting to present, and then we'll come back. But thank you for your questions. That's been excellent. Matea, we can see your first slide if you want to put it on slideshow, and I'll let you carry on.
Okay, hello everyone. Me and Andrea will talk about the experience in Slovenia, and we will mainly focus, our experience is focusing on long-term care system in Slovenia. Regarding the Slovenian healthcare system, let's say Slovenia operates a compulsory social health insurance system with a single provider. That is Health Insurance Institute of Slovenia. Insurance provides near universal coverage, meaning that less than 1% of the population is not covered, and these are many people whose residence status is unclear. The compulsory health insurance does not cover all financial costs incurred during the treatment, so the remaining part of costs is covered by supplementary health insurance, and this one is, of course, voluntary. So healthcare in Slovenia is provided at 3 levels. Primary care, the basic one, meaning general and family medicine specialists, dentistry, pediatrics. This one is provided in community level healthcare centers and by private practices. And in this case, Slovenia operates a typical gatekeeping system in which patients need a referral for an outpatient specialist or hospital consultation. Although the primary care system is quite strong, let's say, the service organization and delivery overall are highly fragmented. So moving to secondary level of healthcare, we have here hospitals, health resorts, medical specialists, and so on. And tertiary healthcare addresses the most serious illnesses, injuries, and other conditions. So what Slovenia is aiming to achieve in healthcare and long-term care, and connected with the theme of our SCIROCCO project, we could point out 3 main challenges. First one is to improve home care. So we aim to have better home care, meaning prioritizing home care. And this means that we want to introduce more health and social services at home of the users. But not only more home care, but also integrated home care, integrated services of care. So meaning both vertical and horizontal integration. So on one hand, along health sectors, and on the other hand, integration between sectors and services. We are talking about especially between social and health sector. And another important goal for Slovenia is related with long-term care system. Let's say for last 15, 20 years, Slovenia is aiming to regulate this field. In this period, already 5 proposals of the law were prepared by different stakeholders. And a few years ago, also Directorate for Long-Term Care at the Ministry of Health was established. So we can see that there are quite a few efforts to systematically regulate long-term care, especially in the last years. And we do expect a new proposal of the law in the near future. So what does integrated care mean for Slovenia? So in this context, and especially in the context also of SCIROCCO project, We focus on integration of health and social care services in end sectors in long-term care. And because existing services are highly fragmented and not integrated into one uniform system, so in practice, there is no, or there is a weak coordination of services, which makes accessibility to services, of course, more difficult and decreases the quality of the services, the quality of the care. Let's say, for example, for social care at home, which is regulated nationally and organized and co-financed by municipalities, is delivered by very different prices and still not in every municipalities. And in many municipalities, it is available only weekdays in the morning. So we can say beneficiaries are not always provided with the quality services, equal and needed services. So I will give the microphone to Andrea, and she will talk with you about the experience of the SCIROCCO project.
Yes, hello. So actually then when, as Matteo already mentioned, we decided to basically focus on integrated long-term care in Slovenia. And also we were in several years of trying to develop long-term care services on the national level. We came to a point where we thought it was there's no more way to go forward there, so we should probably start from the local level as well, from both sides. So that's why we decided for the SCIROCCO Exchange project to choose one of the Slovene municipalities, and that's the municipality of Trbovlje, which you can see in the picture. Even if it's a city in Slovenia, but it's actually a very rural area surrounded by hills, and it's basically a valley between a few hills, and mainly rural with lots of villages surrounding the block of flats. We chose these municipalities because it has very little success in basically performing social care, because it has very bad conditions with a lot of old people, but also providing small amounts of home help. So this municipality, and we invited 3 municipalities, and they were all very eager to collaborate, and there was lots of interest. So we are, during the project, going to do the maturity assessment in more than one municipality. But in Trbovlje, it was already finished, and we involved there 10 stakeholders, basically all the health and social care authorities, plus some public universities, or adult training education centers, youth centers, and so on, who are all involved in somehow meeting people in need of long-term care. So at the end, basically out of those 10 stakeholders, 9 responded to the on the online tool, and 6 out of 9 came to the workshop. Total number of attendees at our workshop was 8, because 2 of the organization, the Health Center and the Center for Social Work, which are probably most interested in developing integrated care in Slovenia, were joined from those 2 organizations. 2 people joined the meeting. Basically, how the meeting was organized, it was organized in the hall in the municipality building, and all these different stakeholders who really work in very small distances, basically very rarely meet, but work with the same group of people and so on, and very rarely talk. So this was like one of the few opportunities for them to basically or one of the first opportunities for them to sit together and discuss integrated care. So first, basically how we organized this consensus workshop was that we first presented the individual results of each of the assessments and explained again the SCIROCCO tool, because for some of them it was quite hard to understand what integrated care means, what several dimensions means, and so on. But then at the end of, when the discussion started, it was quite a vivid discussion, and basically one of the quite important statements made was that basically we're all, like what we wrote here is that they had the feeling that we are all the time just waiting for systematic changes and moves on the national level, but nothing then changes on the local level if we don't join strengths together. So then at the end, our spidergram looked like it's in the picture. Basically, so we can see that on all the dimensions, the maturity showed to be very low, but the success, one of the successes already implemented, where they saw all the stakeholders that there's been a great improvement, is the development of the digital infrastructures. And what they mean here is that they had like a telecare project. It doesn't mean to have they still don't have a joint e-care or e-health IT system, but it's just this small thing. Then another success factor, basically, which was the result of this meeting, there was a decision made at the consensus workshop to employ a social worker at the hospital to coordinate basically after patient care, because they noticed that's a big problem. And the third thing that also came out of this meeting is that they recognize that in order to develop integrated care, obviously people working in the health and care system, they need to meet and discuss. So the municipality took over the responsibility to organize these meetings. On the other hand, they also faced lots of challenges, even if they decided to organize lots of these local stakeholders meetings. The issues of capacities and knowledge that there is in the local environment. So there would for sure be some sort of need to for capacity building, and also on how to really organize coordinated joint actions in integrated care. And the third thing, probably one of the challenges, is how to basically evaluate what's currently happening in the local environment and the new actions that will be decided to be taken on these local meetings. So basically what we probably learned from this process is basically that, especially in probably our countries, but I think lots of other post-socialist countries face the same issue, is that you can't always just wait for top-down solutions and strategies to be planned, because they quite often are just planned strategies. They are not implemented. So with starting bottom-up approaches and joining people that already work in the local areas to work together, meet together, is probably another way to go on. And then from the bottom up, put some pressure on the national level to develop new integrated long-term care services. Thank you. That's all from our side.
Thank you very much. Really interesting insight. And I really like your take-home point about working from the bottom up and using what you can, and perhaps some of the outcomes from the maturity assessment to leverage the discussions about capacity building or about other things in your region. I'll just go back to the chat. I know we're a little bit over time. Thank you very much. We still have 29 people with us, so I will just quickly go back to the chat. Renee was asking if we had guidance for patient involvement, and just to let you know that Andrea had replied in the chat function to say, although there isn't guidance at a project level, it was planned and managed by organizations when they were applying the tool, and that we can share the reports if people feel that would be useful to better understand how the processes were undertaken. And also a point that agreeing that we need to ensure appropriate service user involvement, but would anticipate individual partnerships would be mindful of legislative requirements, any statutory guidance, and best practice principles to involving people as a supplement to using the tool. So thank you for those points. And we had another point which was raised, slightly general, but actually relates to the domains, which says that some issues tackled in the dimensions may exist as general or specifically in relation to integrated care. For example, digital infrastructure. That's a general challenge for us, but also specifically in relation to integrated care, which is dimension 3. That may be relatively well developed overall in a region or country, but not specifically or explicitly for integrated care. Same for process coordination, which is dimension 4. And then goes to ask, how do you deal with that? Do you really rate the dimensions only focusing on integrated care? So Matea, if you want to have a stab at answering that one before I open it up to the other presenters, please.
Excuse me, can you say once again?
Yep.
What the question was?
So the question is, there may be a challenge or an issue that applies across your service, but do you really only rate the dimension that is focusing on integrated care? I'm not sure if I'm explaining that hugely well. Yeah. So apologies to the person who posed that question.
Yeah, okay, we can say we try to focus as much as possible on integrated care, but of course when you enter in the local environment, they have loads of issues and questions, not only about like old age people, but also of young. For example, in this municipality, there's lots of work with young people using drugs and so on. So of course they try to you get all this team. When people they discuss all these other themes and issues as well. But what we try to do, we try to focus on integrated long-term care. And then also, of course, in the discussion, we said that there's also obviously other issues that the municipality should cover and prepare a strategy or on a plan on how to develop further. But that was how we tried to deal with it, and we tried to stick with this long-term care. But of course, when especially in these rural municipalities with lots of questions unanswered regarding social and health care, not just about long-term care, you could see that there would be a need for an overall social and healthcare strategy, not just a specific on long-term care, but also on how to develop youth services, how to develop services for people with disabilities, how to deal with poor people and homeless people and so on. But yeah, for the moment, we just focused with them on long-term care, or we tried to.
Thank you very much.
Yeah.
So I'm just going to ask if there are any final questions that anybody wants to pose before we say thank you again to our speakers. And oh, I think we have one. It's a question from Renee. I'm not sure, Andrea, if this is a question for you. The question is from Renee, is who decides on the next steps? I think, Renee, I don't know if you are able to unmute yourself or if you wish to unmute to expand slightly on that. I'm presuming you're meaning once you've used the tool and you've identified these challenge areas, or you've looked at your spider diagram, what happens next in your region? Is that what you mean with that question? So Andrea, perhaps I can ask you if you can give a bit of insight from across the project about that. And then there's another question, which is from Yuska. I'm probably pronouncing that really badly. If some country were interested to use a SCIROCCO tool in the future, what is the procedure? So that's definitely one for Andrea. So the presenters are getting off easy here at the moment. So Andrea, if you could please give a little bit of insight on those 2 points.
Yeah, maybe I'll just start with the second one, as it will be probably shorter reply. So as I was saying, the tool is available and free to use. So anyone who is interested can contact us as a project coordinator, just to basically for us to get a bit of idea how you want to apply the tool, and you know, if you need any assistance. But in principle, there is a link on the SCIROCCO Exchange website. So basically you can use the tool even without contacting us. But in case you're looking for some, you know, further involvement or some support, then definitely just please get in touch, and we will be happy to support you in the application of the tool. With relation to the next step, so you know, within the project we have used the maturity assessment as the first functionality within the knowledge management hub. So for us is basically now when we understand the areas that regions want to take forward for further improvement, we are going to undertake some knowledge transfer activities. So we will be conducting some you know, study visits, webinars, exchange of staff, and different levels of activities to reflect the ambitions and objectives each region has. So we will be developing SCIROCCO Exchange knowledge transfer program, which we actually are working already on, where which basically includes a set of activities where regions can undertake further learning in particular domains, and you know, which they identify at the maturity assessment level. I also mentioned that we want to work with the existing evidence and with the existing experience. So as part of this knowledge transfer, we will be using the existing good practices, you know, repositories that are on the market, various outcomes of national European projects. So we have mapped over 300 of these assets within the SCIROCCO Exchange regions and almost 3,000 at the wider European level. So we are now just working on linking these assets directly to the Knowledge Management Hub. And again, it will be available for everyone who is interested to look for the resources. And in the last stage, as a result of this learning and basically facilitating the access to these you know, good practices and various levels of evidence that exist, we will be working individually with the regions on their improvement plans and what needs to happen in each region in order to increase their maturity along the dimensions as they identify for the improvement.
Thank you, Andrea.
Mm-hmm.
So I don't see any further questions, and as we are a little bit over time, I would just say thank you once again to the presenters for giving their time to share their experience. That's really been interesting and helpful. I hope the people who have joined us have found it interesting as well. And the recording will be made available shortly after today's webinar. And if you want to contact us through the SCIROCCO Exchange website, the link, the URL is available. It's there in the chat. It's just www.sciroccoexchange.com. So you should be able to find us there. Thank you very much, everybody. I'll say bye-bye.
Thank you.